Okay, for this week's review of emerging and infectious diseases, we're going to be focusing in on respiratory diseases. Now, as always, when we review diseases, we want to try to give some coverage of name of disease, pathogen. Maybe it releases a toxin, maybe it's an endospore respiratory. What is its metabolic respiration, metabolism? Where are the locations of the pathogen? Are there any reservoirs? Also, what are the signs and symptoms? Is there any type of treatment, whether it's antitoxins, antibiotics, antifungals, antihelmintic, and antiprotozoal drugs? And also whether there is a vaccine. So let's get started. When we review the respiratory modes of transmission, you have three primary ones. One is contact transmission. Some respiratory diseases are transmitted by direct contact with contaminated hands, doorknobs, or other shared items. These are fomites. Okay, so somehow the pathogen is present on these things. People handle them, and they may then eventually rub their noses or whatever, and they get it into them. Another mode is droplet transmission. Now, in this category, the agents land directly on the mucosal lining of the nose, mouth, eyes of nearby persons, or it can be inhaled. A lot of times when we cough, when we sneeze, we're expelling at a very high speed particles that may contain the pathogen. Even if the particles are droplets, the moisture can also evaporate out of them, but they still will contain viable pathogens. And of course, then we have also, obviously, the airborne transmission. Now, this refers to infections that are generated when an ill person sneezes, coughs, or speaks. Yes, speaking can be a means of transfer. And this is a particular critical situation when it's a disease that there's not easy types of treatment. Two of them that I'm thinking of, well, we had COVID, and lots of people had to put on masks. But then we also had, prior to that, Ebola. And so someone sneezes, they cough, they're literally bleeding out, but those particles that they cough up become airborne, and without the proper mask, etc., the next person will get that ailment. And you can see this illustration here. Normally, droplet size and the distance traveled are related. And what I mean by that is large infectious droplets, they're not going to go very far, 1 to 3 feet. Smaller particles, smaller infectious droplets, might go 3 to 5 feet. If you have infectious droplet nuclei, they can go 5 to 165 feet or 160 feet or more. And what this is usually when the droplet has basically lost a lot of the water, hence a lot of the mass. So it becomes easier to move around, especially in crowded areas, especially where there might be some type of breeze or ventilation, etc. And so this becomes something that's easier to transfer. So what are the standard precautionary measures? Now, if you can see this is the hierarchy of controls now. We may have mentioned them before, but infection prevention practices apply to all patients in a clinical setting, not just those with an infection. So as you can see here, the least effective is something around the range of protection protect the worker with personal protective equipment. But then you continue to move upward to the point where you have you physically remove the hazard, and that's elimination. You can replace the hazard, that's substitution. You can isolate people from the hazard, that's engineering controls. And then, of course, change the way people work, which is administrative controls. Okay, so when we're talking about something that gets airborne, this may require a variety of strategies beyond just PPE. It may be administrative. It may be that you physically remove the hazard and isolate the people from the hazard. You may put individuals in quarantine, etc. So you want to start thinking about that. How would you, if suddenly tomorrow someone had something that was very, very airborne, and what's the most effective strategy to prevent them from getting an ailment? Then we have also contact patterns. Now, if you remember when we were talking about contact tracing, now from respiratory illnesses in particular, contact patterns are key factors in determining the transmission. This is because you're dealing with situations, social mixing patterns across different population groups, often within and between age groups or households, affect the likelihood of transmission. So just to give you an idea, if you think about a rave versus people coming to a movie theater versus people at a family birthday party, you have different factors there. But if someone within that group is infected, they can easily transmit this pathogen, especially if it is respiratory. Okay, and finally, we have to deal with the issue of contact investigations. Now, as we saw with COVID, there was all sorts of variations between cooperation, non-cooperation, and just difficulty in tracking individuals. Keep in mind that contact tracing provides a systematic process to identify people, known as contacts, who have been exposed to cases of an infectious disease. And so this provides us with information revealing the transmission chain. Now, you have to understand what I'm talking about here. It's not just a matter of finding patient zero. It's a matter of finding out who was exposed and who is going to be the next cases and who they're going to expose themselves to, etc. So if you take a look, you have all of these kind of orange-colored individuals. These are contacts. You have the index case here, the individual who initially had the ailment, and out of all of these, somehow you had a secondary case. And you start seeing several of them getting sick. They're going to be the tertiary case. Now, in something like a cold, flu, that may not be as, really exciting and really helpful. In something where it's respiratory, but very deadly, like COVID, at the beginning of when we had the shutdown, that's a completely different ball that you have to play with, in the sense of a baseball. Like, what you have here is you have to start tracking down individuals. Now, we have pretty much relaxed all of these procedures, but in the beginning, it was important. You would find out someone was sick, and then you would start asking them, okay, who were the people that you were with or could have been with you? And then they move from that individual to the next group of people, find out that one or two is sick. Okay, who did you come in contact with, and it continues to move forward. So, with all of that known, let's get into some of the real situations here. Now, in some cases, I'm going to talk about the ailments, about the pathogens, etc. But sometimes they're not merely cut and dry. And what I mean by that is, for example, community-acquired pneumonia, bacterial. There are situations where there are a couple of specific bacteria that cause the bulk of these cases, but there are others that have similar cases of pneumonia, but they're of a different type of bacteria. Okay? So, community-acquired pneumonia, CAP, is one of the most common acute infections requiring admission to a hospital. Now, the main causes of pathogens of this are Streptococcus pneumoniae, influenza A, Mycoplasma pneumoniae, and Cladiomonophilia pneumoniae. What's the major risk factors? Age, smoking, comorbidities. It is important to note also that S. pneumoniae and MRSA, okay, can lead to necrotizing pneumonia. In other words, the tissue in the lungs begins to die. Okay. Pneumonias caused by chlamydia, mycoplasma, are often clinically indistinguishable from other pneumonias. The C pneumonia accounts for about 2 to 5% of CAP. This is the second most common cause of lung infections in healthy people aged 5 through 35 years old. C. pneumoniae is commonly responsible for outbreaks of respiratory infections. This will happen in situations like within families, college dorms, military training camps, etc., when you have a large number of people in relatively confined area. Fortunately, it causes a relatively benign form of pneumonia that infrequently requires hospitalization. Chlamydia piscati pneumonia, otherwise known as psittacosis, is very rare. It occurs in patients who own or often are exposed to psittacean birds. In other words, these are the birds that we have, a lot of people have for pets: parakeets, parrots, macaws. Now, the symptoms and signs are fever, cough, sputum production, pleuritic chest pain, dyspnea, tachypnea, and tachycardia. In seeking medical help, it's necessary if that patient starts showing signs of difficulty breathing, chest pain, persistent fever of 102 or above, or persistent cough, especially if the patient is coughing up pus. Okay, so there's a major interaction of the bacteria with the immune system, etc. The prognosis is usually excellent for relatively young and healthy patients, but many pneumonias, especially when caused by S. pneumoniae, Legionella, Staphylococcus aureus, or influenza virus, are serious, and they can in some cases be fatal for older, sicker patients. So what is the treatment here? Now, this is going to be for the bacterial types. Okay, I want to keep that in mind. Usually there is a type of approach which is you do empirical treatment. And that's sort of, you give the antibiotics, and you would only change if, after culturing, you see, this isn't going to do, we've got to switch over to this particular type of antibiotic. Okay, so basically when you're looking at this, first and foremost is amoxicillin. You give it about 3 times a day. You also will include a macrolide. That's another type of antibiotic, such as azithromycin, clarithromycin, or doxycycline. Generally, it's preferred to use a macrolide over doxycycline. Now, if you look here, these are some of the images in your reading. And if you notice, let's go from left to right here. Okay, so in here, the lung of pneumococcal pneumonia. And you can tell you've got mixed red and gray hepatization. This is a transition stage that you see. Pleural fibrosis, and you also have an exudate. Okay. Now, you have all these zones. I want you to take a little bit of time and review. If you move over to here, you're dealing with something a little bit different. This is with staphylococcal pneumonia. Usually to verify it, you use a coagulase test, which is a microbiological test. And you use plasma, and basically you have that with a clot. And you also have a control, obviously. Now, with severe staphylococcal pneumonia, these are going to tend to cause complications if the patient has endocarditis. They may also lead to abscess formation, empyema, vegetations on the tricuspid valve, and emboli in the branches of the pulmonary arteries. So what you've got is that this moves from lungs, continues to move throughout the lungs, but it also enhances damage to the heart. Okay. If you take a look over here with the Gram stain, you have staphylococcal and PNM in the sputum. Now, polymorphic nuclear leukocytes, they're also referred to as neutrophils. These are the first lines of defense. And as you can see, they're really trying to multiply and go up against the bacteria that are present. Okay. When you look at staphylococcal pneumonia, you can see here the areas where you have a buildup of fluid, etc., that's going to increase the density. So when the x-ray comes, a lot of this is white. It shouldn't be. It should be transparent, i.e. black. This is the early staphylococcal pneumonia. And then we have the late staphylococcal pneumonia. And you've got abscesses and you've got a pneumothorax right up in here. Okay? Keep in mind a pneumothorax is when you actually have in the basically the pleural membrane that you've got is air that's in there. And usually that's in part because the lung may have an opening because of the damage that's occurred. And so some of the air may be going from the lung right into the pleural spaces. Okay? So move from here. And you can see some of these other characteristics which Netter is well known for. In this case, you have the Gram stain of sputum. It's got Klebsiella pneumonia. And you can tell this, what happens is that you take some of this and you culture it, and you get what is characteristic of currant jelly. In other words, it is thicker, almost like viscous, maybe slimy, slightly translucent, strings itself out when you take this inoculating loop, touch the colony, and pull it out. Okay? You can see here the lateral chest films, the pneumonia chest films, and here's the damage caused by Klebsiella. Remember I said that if you take an x-ray of a chest just as it is, you're going to get a lot of empty space there because that basically it's bone that will stop x-rays, and so you get a white area. But if it doesn't stop it, you get a black area. And so what's happening is you're getting this mixing here. This is beginning to build up in damage up in the upper lobe of that lung. In other cases, no. Now, one of the other things that you're going to see is if you go over here, cases of cough with normal chest x-ray and cases of chronic cough with abnormal chest x-ray. What's going on? If you look here, you've got postnasal drip, and you got the vagus nerve firing off, and you look at this and you see chronic bronchitis right here. And with asthma, though, you get a major bronchoconstriction here. This is more or less like a bronchodilation here, okay? And this is going to be very difficult to breathe. If you move to the chronic cough, you're going to start seeing the primary complex here. And one of the things that people don't talk about enough is that there are lymph nodes around the bronchi going up to nearly the coronae of the trachea for the lungs. And you're also going to have a lot of dilated air sacs being the alveoli. What else are you going to see? You're going to see, eventually, if it's chronic, carcinoma of the lungs. You will also see the static muco-filled spaces. Now, what's going on here is that some of these alveoli are beginning to fill up with mucus, and that's all that occurs. You have the left-sided congestive heart failure and pulmonary hypertension. There is such a difficulty in allowing gas exchange as the blood is moving from the heart to the lungs and then back, that you're going to start having more problems with the heart getting that supposed oxygenated blood out to the systemic environment. The bacteria that enter in this area will cause some damage. You will also have some areas where you're not going to get normal blood flow through the lungs. And those areas are going to cause eventually what's called congestive heart failure. Okay? So, moving on, we get into hospital-acquired pneumonia. By the way, hospital-acquired pneumonia used to be referred to as nosocomial pneumonia. In other words, this is pneumonia you get in the hospital. And it's referred to as HAP, hospital-acquired pneumonia. It develops at least 48 hours after hospital admission. And so what happens is you have someone that's being brought in, they're getting treated for something, and then they start having some unusual symptoms, and they now have pneumonia, okay? Now, the most common pathogens are Streptococcus pneumoniae, gram-negative bacilli such as Staphylococcus aureus. Antibiotic-resistant organisms are also of a critical concern here, okay? The signs include malaise, fever, chills, rigor, cough, dyspnea, and chest pain. Now, HAP usually will occur in patients who are hospitalized for 48 hours or more. The development of HAP depends on factors like the age of the patient, underlying comorbidities, and immune status. And by the way, I'll throw in, yes, smoking. The mortality due to HAP is estimated to be between 5 and 33%, which is really stunning when you think about that. Also, all patients that are treated should be empirically treated with antibiotics that have an anti-pseudomonal or other gram-negative activity, such as piperacillin, tazobactam, cefepime, levofloxacin, or a carbapenem. Now, here's the point. If the patient is not high risk for mortality, but they have an increased risk of MRSA, then you have to select for an anti-MRSA antibiotic. those would be something like vancomycin or linezol. Okay. And here you have the hospital-acquired pneumonia, and you have vasculitis, alveolar hemorrhage. Person is coughing up blood because some of the alveoli have broken up. Okay. They may expand again later, but you're having the capillaries broken at the same time that the alveoli are damaged, and so blood is going to come into the respiratory area of the lungs and then move forward. You're going to get a pneumothorax here. Aspiration pneumonitis is a possibility, as well as pulmonary infarction, okay, and congestive heart failure. Okay, now these are the non-infectious causes of an abnormal chest radiograph because of HAP. So, what about over here? The patient requires comprehensive testing for suspected HAP, that pneumonia. So you have chest radiographs, sputum culture, or gram stain. You want to do laboratory evaluations. One of the other things that occurs is that doctors will put in a bronchoscope down to evaluate what's going on in. They're not going to get into the alveoli. They are going to get into the areas of the bronchioles, etc. Okay, now I got another little question here. What happens if the lung collapses? If the lung collapses, usually that means you're having space, air in the space between two layers of the pleura, and so the pleura help keep the lung patent open. The lung collapses, you've got to get that air out. Okay? And you can see also how they monitor things is with an arterial blood gas. So, now, here we have complications of a hospital-acquired pneumonia. They include cavitation, okay, collapsure of some of the areas. Notice this, this, and this. What you had, if you think about it, alveoli are extremely small, but they start breaking down. Now, the respiratory membrane is being reduced. You will still get an open space, but the open space is much larger. And as a result, you won't have gas exchange occurring. You have empyema right up through here. You have lung abscesses. That's really bad. Because what you have to think about is this. The lung has to be pliant. It has to be able to do a little bit of expansion and a little bit of contraction. An abscess would interfere with that capability. Now, you will also have the possibility of bacteremia with and without endocarditis. So you can see here the bacteria that's forming vegetations on the valves of the heart. So when we talk about risk factors, we go back here, and what are we looking at? Now, this is for hospital-acquired pneumonia. Now, yes, before you even start, I know people should not be smoking in a hospital. Okay, so they don't. They go outside the building, they sneak out, have their favorite cigarette, and then go back in. But it's still continuing the subtleties of stress, risk, and eventual damage. Some of the others, of course, are chronic underlying disease, advanced age, immunosuppression, obesity, malnutrition, altered level of consciousness, smoking, as I mentioned, alcohol abuse, and drug abuse. Now, the treatment-related risk factors include also intubation, all right, enteral feedings. If you remember what an enteral feeding is, you're basically not digesting through the food through the normal digestive pattern. You have this solution, basically containing some monosaccharides, things like that, simple lipids. It will also contain a variety of amino acids, etc. And that will be put directly into the venous system by this enteral feeding process. Some of the other ones that are related include recent surgery. Now, if you think about it, how did they get the bacteria down here? Maybe they had to go after, in the recent surgery procedures, a lot of bacteria that had caused sepsis or causing the flesh necrosis, or just out and out just causing damage at a particular area of the body. You can also have HAP if you enter the ICU, okay? And in some cases, that is really incredible when you think about it, because you have the machines breathing in essence for you. It's possible that something can get delivered into the lungs that way. And then also recent antibiotic exposure. Before I go any further, let me just give you a perspective here. Okay, I had a nephew, and this was up when I was in Massachusetts, and so he had to stay overnight, and there was another young person in the neighboring bed. Now, this person's, I'll just say, ethnicity and culture really encourage, the family all comes in at the same time. Are they really supposed to be two? Nope. Well, unfortunately, when one of them came in and sat there and chatted with that other young man and left, it wasn't until later they found out that that particular individual had come into the hospital with tuberculosis. This is one of the issues you have to be aware of, that in some cases, HAP comes in not because of anything that the hospital is doing, in the sense of failure to keep clean or something else like that. You have a lot of sick patients come in, and some of them will spread in this very limited space facility, waiting room, ICU room, etc. They'll spread the disorder by coughing or sneezing or whatever. Moving on. And finally, if you're an aficionado of the television program House, this is similar in the sense of what they call differential diagnosis. House oversees a team, and sometimes they take all the medical data first and they start doing differential diagnosis, trying to figure out what the ailment is. And every once in a while, there'll be this banter going back and forth, and I'm not talking about necessarily the rude comments to each other, etc., but it's sort of like, well, that can't be because they have normal blood pH. That can't be because they did a spinal tap and they found nothing. And so what you start doing by this deductive reasoning is ruling out those factors that could have caused this HAP. You will see that in some cases it's a venous catheter infection, a urinary tract infection, Clostridium difficile colitis, aspiration pneumonia, telaxis, pulmonary embolism, pulmonary contortion, drugs, acute respiratory distress syndrome, and also you'll have a few situations where neoplasm. Yep, that's lung cancer right there. Okay? So, off we go to the next one. And by the way, I broke down pneumonia into several different situations. because it helps to kind of winnow through all the possibilities, and it helps in understanding the causes, the treatment, and also how this particular ailment occurred. The next one we're going to be dealing with is atypical pneumonia, otherwise known as walking pneumonia. This is a community-acquired pneumonia, but it's very unusual. It's atypical. Remember that pneumonia is inflamed or swollen lung tissue due to infection with a germ. Atypical pneumonia, the infection is caused by different bacteria than the more common ones that cause pneumonia. For example, Mycoplasma pneumoniae is responsible for the vast majority of atypical respiratory infections. However, only about 10% of the patients who acquire the Mycoplasma will develop pneumonia. Mycoplasma pneumonia infection tends to be more common with advanced age, especially with the elderly. Walking pneumonia its causes may include bacteria, viruses, or molds, also known as fungi. So there's a whole array of those. Most cases of atypical pneumonia are easily treatable. Usually, though, people have less severe symptoms than those with typical pneumonia, and the infection may go away on its own. Okay, that's nice, because it's an issue of severity that you have to keep in mind. But walking pneumonia symptoms will include sore throat, which is the pharyngitis, extreme tiredness, that's fatigue, chest pain or discomfort, low-grade fever, less than 101 degrees Fahrenheit or 38 degrees Celsius. Mild chills, cough, sneezing, and headache are also some of the other symptoms. How do we treat it? Most of the time, you're going to have a situation where the individual is going on an outpatient-based prescription with a macrolide antibiotic such as azithromycin, clarithromycin, and a lot of times you'll also have assisting with it tetracyclines, which are doxycycline and tetracycline. You may also include the fluoroquinolines, such as ciprofloxacin and levofloxacin. Now, if the patient has a fever, they should drink more fluids and rest. Non-steroidal anti-inflammatory drugs, NSAIDs, can also be very helpful in helping to reduce the fever. The interesting point also is that people start feeling better within 3 to 5 days, but the cough from the pneumonia can last several weeks or months after treatment. And here you see this. This is Legionnaire's disease. Now, this is part of the atypical pneumonia, and I'll explain something for you. 1976, there was a convention of Legionnaires, that's where the disease gets its name, in Philadelphia, Pennsylvania. So you had people of varying ages. Okay, we're talking 70s and 80s, 40s, 50s, and 60s, etc. Okay, so some of them would have had no problem fighting off an infection. Others, it gets more difficult. As you can see here, you have, of course, the Legionnaire disease bacteria, and you have a 58-year-old man with serologically confirmed Legionnaire disease, the left lower lobe. Within 2 to 3 days of initiation of treatment with erythromycin, fortunately, radiological changes did not completely disappear, though. In other words, remember, this is kind of open up, and you start to have this where you provide a lot of junk and things. it's going to have that calcified image. Finally, we look at this, and you have an H&A stain, hemoxilin and eosinophen, and they were extracted actually from the fatal case of Legionnaire's disease. They basically will involve residue that's present, maybe dead cells with DNA present. These will end up making large macrophages. Then we move over to the right side here, and we have mycoplasma. Now, mycoplasma, you have the eating agent, the pneumonia, the primary atypical pneumonia. And you can see here what's going on, the various tests, the complications that can start because you're not protecting a particular individual. Okay? And what happens is that the mycoplasm continues to proliferate. It may also kill off the initial patient with it. If you also look at the clinical course here, I'm not going to spend too much time. You'll notice how you have this onset of headache, malaise, cough, and rales. Rales are kind of like a funny stridor or air coming out, air coming in, but it doesn't have a nice smooth sound. It's more as if it's grating against the lung tissue. Okay. Now, excuse me. Now we're going to get to aspiration pneumonia. And this is very interesting because of the fact that really what it is an infection of the lungs. It's caused by inhaling saliva, food, liquids, stomach acid, vomit, and even in some cases, small foreign objects. It can be treated with the appropriate medications. Yep, no problem. If left untreated, though, complications can be serious, even fatal. Now, the bacteria involved in the aspiration pneumonia may be either aerobic or anaerobic. So they may be Streptococcus pneumoniae, Staphylococcus aureus, Haemophilus influenzae, Pseudomonas aeruginosa. Sometimes you'll get some chlamydia. Okay? That's often seen in aspiration lobar pneumonia. And by the way, this particular type is very common with alcoholics. Now, anaerobic. They also play a key role in the pathogenesis of aspiration pneumonia. Keep in mind, anaerobic, without air, without oxygen. They have different means to proliferate. So, basically, here is where you get some also unusual forms of bacteria. Bacteroides, Prevotella, Fusum bacterium, and Streptococcus. Okay? The symptoms may include any of the following: chest pain, coughing up foul smelling material, greenish or dark phlegm. Okay, so the sputum is coming up. It's either greenish or it's black. Okay, and you can see some of the other situations here. Besides pus, you could have fatigue, fever, shortness of breath, wheezing, breath odor, and excessive sweating. Now you have to keep in mind that there are two phases following an aspiration of the stomach contents into the lungs. First phase is a non-specific situation, and basically this begins a few minutes after the aspiration. the phase is due to chemical injury. Second phase is an inflammatory response. Now, the first phase, you may be having individuals coming home late. You may have them somewhat lost. They've got to find some place to eat. Or they may be having several different comrades of the same team coming home. It doesn't matter. What matters is, for the World Health Organization, you have one of the keys to very important life-saving tools. What about antibiotics? Well, the recommended ones include clindamycin and meropenem, atropine, amoxicillin sulfabactam, and moxifloxacin. And the treatment with piperacillin, tazobactam, with cefepime, and with levofloxacin, imiprium, impendium, and the meropenem. These are all recommended for cases of potential antibiotic resistance, such as MRSA, right? And the typical duration of these therapies is about 5 to 7 days. If there's a large accumulation of fluid within the lungs, well, the drainage of the fluid may also aid in the healing process. Okay? So, we'll move forward. This is just to give you a little bit of an overview here for the pneumonia and afterwards via macro respiration. Okay? Pathogenesis of and risk factors for pneumonia after microaspiration. What we're talking about is the very small network of capillaries, etc., which of course blood is going to go from the chamber of the heart all the way out to where you would see low population density. Okay? So pathogenesis and risk factors of pneumonia, or for pneumonia after microaspiration or macroaspiration. Macro can occur as a result of abnormalities in the swallowing mechanism, altered swallowing due to a dysfunction of the nervous system. Okay? This is more an algorithm which gives you an idea of what kind of ailment it is. If it's this, these are steps all involved with basically community-acquired aspirational pneumonia. If you have a situation such that you end up with hospital-acquired HAP, you're going to get a bunch of doors slammed in your face. Abnormal test, photograph, the clear test, radiography, and you can see what these choices are here. Okay, so I want you to take some time and review that. Now, respiratory diseases. Aspirational pneumonia, as you can see here, these are the characteristics, basic characteristics emanating from the filing in patients with aspiration pneumonia. On the left is a 56-year-old male with a cough after tooth extraction under local anesthesia, and he thinks, he drinks 4 cups or 4 beers a day. And bronchoscopic cultures revealed Klebsiella pneumoniae. Now that's an A. Okay. B, you have someone that's much older. It's a 79-year-old male with dyspnea and new bilateral infiltrates following the upper endoscopic complication via swallowing. Okay? One you're having is more or less sort of a blockage. The other one is a blockage that gets undone. And, sometimes you get sprightly 70-year-olds that will jump through hoops to get out of a burning building. And unfortunately, in other cases, you will have a male stripper who will basically, they're going to have some infiltrates. This is with dyspnea. They have bilateral infiltrates during the upper endoscopy, which is, of course, complicated by vomiting. And you can see here how some of this, it's almost as if it's missing. There is a line here, but it's much more difficult because with all infiltrates that are located in the posterior, the gravity dependent ones are the greatest. Okay, so we've moved out of bacteria for a bit. Let's go into the viral respiratory infections. Respiratory viruses can cause the common cold. Certain respiratory viruses of interest are the respiratory syncytial virus, which there is a vaccine available, RSV. Rhinoviruses, a bunch of those give you the common cold. Enteroviruses, coronaviruses, including SARS, and the MERS-CoV. We have also the adenovirus, the parainfluenza viruses. Within that grouping, some parainfluenza viruses cause a disorder for little kids called croup. And I remember this with my daughter. They had to bring her into the emergency room and give her something to bronchodilate her, to make it easier to breathe, etc. Now, respiratory infections are classified by the causative virus. So we're talking about influenza or other types of viruses. They're generally classified clinically according to the syndrome. So the common cold, bronchiolitis, croup, pneumonia, etc. The causative agents will include adenoviruses, coronaviruses. If you keep in mind the severe acute respiratory syndrome disorder, and number 2 is caused by SARS-CoV-2. The cause of coronavirus disease in 2019 was COVID-19. The common human coronavirus, though, including the types 229E, NL63, OC43, HKU1, all of these basically want to and will cause certain types of disorders. For example, the human metapneumovirus, which some researchers are starting to see this pick up and may be a topic down the road because there's no treatment for it right now. The influenza virus, measles, mumps, parainfluenza viruses, the respiratory syncytial virus, and the rhinovirus. Now, other viruses of special concern are for travelers that include the Middle East. Because the problem is, in the Middle East, you have those selective respiratory syndromes. Those are called MERS. And these are similar to COVID in the sense they are coronaviruses. They're also highly pathogenic. When we talk about avian influenza viruses, if the influenza jumps from the bird, it can be now changed enough to really infect people. Okay, so Let's start off with one of the viruses, influenza virus. The flu is a contagious respiratory illness caused by influenza viruses that infect the nose, throat, and sometimes the lungs. It can cause mild to severe illness and at times can lead to death. What are the symptoms of the flu? These can cause mild to severe illnesses. At times, they can lead to death. A lot of times, they come on suddenly. People who have the flu will often feel some or all of the symptoms, and it'll be sort of a surprise within a day or two from when they started saying, "I'm not feeling too well." So, what are some of these symptoms? Okay, fever, feeling feverish and having chills, cough, sore throat, runny or stuffy nose, muscle and body aches, headaches, fatigue, which can be translated to a tiredness. Now, some people may have also vomiting and diarrhea, though this is more common in children than adults. It's also important to note that not everyone with flu will have a fever. Okay. Prevention, get a yearly vaccine. Now, how come they keep making different ones? Real short and sweet is this. When vaccine producers and public health researchers, they note that influenza tends to show up when it's kind of like summer. So when you have the southern hemisphere and it's summer, it's in the northern hemisphere a lot of winter. When you have summer in the northern hemisphere, you're actually reviewing for the presence of new mutants. In the winter, in places like Australia, Indonesia, South America, Union of South Africa, things like that. If they find that these are devastating enough or warrant serious attention, those are the virus strains that they will begin to make flu vaccines for the northern hemisphere for that coming fall. Usually, a vaccine will last about a year. The prevention. We end up using a lot of times antiviral drugs, and this is recommended by CDC to treat flu for the season. So what are some of the other drugs? Oseltamivir and zenamivir, paramivir, and marboxil. Okay. So here we have influenza pneumonia. If you look here on the right lung, you have intense hyperemia, edema with areas of blue consolidation. The blue consolidation just means there's not as much oxygen getting to those tissues, okay? You also have in a cross section of the lung, it'll be marked by congestion of the bronchial mucosa. You'll have the parenchymal hemorrhage and edematous with patches of consolidation and emphysema, as you can see here. Now, when you get down to the level of the alveoli, the septa, the walls are thickened by edema and cellular infiltrates. Therefore, the capillaries are engorged. The alveoli is filled with fibrin-containing desquamated epithelial cells, leukocytes, and macrophages. Translated, what happens is this. At the membrane, where this gas is being exchanged from blood to the alveoli and back again, with the presence of this virus, the crew that mans that particular station may all get sick and collapse, but also you will see a series of other animals coming in to eat the carrion of dog, sheep, cattle, etc. Okay, you'll notice the secretion of long-showing hyaline membranes and the necrosis of the alveolar walls. So they're breaking down here. Okay. And here is a nice little diagram, a series of diagrams to give you an idea about the appearance, the formation, or the synthesis, and the uptake of influenza viruses. And what is absolutely interesting here is this. Now, the influenza virus, one, has different proteins on the edges. We measure those so we can get an idea what kind of strain or type of influenza you have. So they will measure it by saying HN, and after the H there'll be a number, after the N there'll be a number. And what these proteins do is they help to allow for the virus to get inside the cell and also for the progeny to get out. Everybody with me? Well, it gets even more unusual. You see this loop of nucleic acid? Part of the reason that influenza has the capability to undergo massive genetic changes is because its genome is 8 long strands. It is not a continuous circle that you would normally see. It is, on the strands are the various genes for the proteins that are necessary for viral replication. The proteins on the outer edge of the virus, including hemagglutinin and the other type, basically the N part. You'll have to forgive me if I forget one or two minor items, but neuraminidase, yes. Now, as you can see here, the influenza virus comes onto a chicken embryo, attaches, and then settles itself in. When you start having new strains created, you can have new strains of influenza by two means. Antigenic drift. That means that a gene may have just one small codon change, and therefore the protein products such as the hemagglutinin or the neuraminidase will have a slight change on it. Okay. There may be also some other proteins that are inside here that may undergo some changes. That's drift. It happens a little bit more like not very frequently, but it happens a lot. The other type is called antigenic shift. That's when you have some of these, what they refer to as cassettes. In other words, these 8 long linear strands of nucleic acid. And they are shifted so that one cassette, one unit is left. Some of the other ones have lost their way, others have deserted. But what you're seeing is, as a result of some mixing of RNA with other RNAs, you're going to get a virus with new traits. Now, this particularly will happen if the influenza, let's say we have an influenza strain that infects humans, it infects a cell. We have another influenza strain that it infects normally either bats or pigs, and it is also at the same time infecting that cell. So now you've got this almost like soup inside the cell of these genetic cassettes. And therefore, when you start assembling and putting together these new viruses, they're not going to have the entirely same amount they started with. They will still have 8, but one of those cassettes may not be from human virus. It may not be from a bird, but it could even be from a bat. Okay? And so now you've got an influenza virus with a series of new types of traits, and perhaps in some cases, an enhanced lethality if it infects humans. Now, I'm just going to expand upon this a little bit with avian influenza and pandemic influenza. When we talk about a pandemic, this would be, for example, with the human flu, it would affect millions of people all around the world. When you have an epidemic, that can occur in a single country. By the World Health Organization designations, a pandemic is when the disease jumps the borders, spreads beyond just one country, maybe 3, maybe 4, and that's when they sit there at the United Nations, at the World Health Organization, go, uh-oh, we've got a pandemic on our hands, okay? Now, very rarely you have avian flu virus. And this is caused by RNA viruses that will infect a person. And a human pandemic will not happen unless the avian flu virus changes in such a way that it's easy for people to spread the virus from person to person. Case in point, 2008, 2009, they were all getting worried about an avian influenza outbreak. Here's the problem. They were monitoring this one particular strain of avian influenza and trying to see if it would basically become an influenza infecting people. The flu virus only went so far down into the respiratory tract. Had it gone deep into it, such as into alveoli, bronchioles, bronchioles, and bronchi, etc., yeah, no problem. It has to find certain cell receptors to bind to and get inside the cell to reproduce the virus. Fortunately, that type of influenza never really got to the point of evolving to be a serious threat to humanity. But you got to keep in mind something, that people that are in direct contact with infected animals through handling, culling, slaughtering, processing, or they might be through indirect contact, through environments contaminated with body fluids from infected animals. These will represent a risk for human infection. The wet markets in China is an example. You want your chicken? You can buy your chicken, but it's alive. So right there, they will cut the head off and get it ready for you somewhat. And this is also something that happened because you would have situations that would occur in China where people not only ate pigs and birds, but also bats. And so some of the components of the influenza viruses may have mixed sufficiently to become something that would jump the species barrier, that is birds, and become infectious to humans. Now, the other issue that they have to deal with influenza viruses is that you have a natural reservoir in aquatic birds. Now, what I mean by that is, like ducks, geese, etc., but also the wild birds that are migratory, especially waterfowl, yeah. And they're impossible to eradicate, okay? So you've got lots of these birds that fly between, let's say, Canada and going into Central America, and then on the way back, and they may go into certain water areas where there are other birds and spread a new version of influenza. From time to time, they will have to monitor worldwide the migratory patterns of birds just to see if these particular birds will have the infection and spread it. Okay? So, zoonotic influenza infections will continue to occur because there's just no way. You can't eradicate all the birds. So, how do we treat this? Well, one of the best ways to prevent is really a flu vaccine. Okay? But if, let's say, the infection is severe enough, some doctors may then increase the treatment by using the antiviral medicines such as oseltamivir, which is otherwise known as Tamiflu, and zanamivir, which is also known as Relenza. Now, you have to be mindful of one thing. Doctors are not going to just hand these out like candy. We're going to deal with later on the issues of multi-drug resistance. And one of the biggest fears that some infectious disease specialists have is the same means that were used to distribute all sorts of antibiotics for all sorts of ailments and didn't necessarily do anything. The few antiviral drugs we have out there will eventually have viruses developing strategies against it, and then it's useless. Let's go to the respiratory syncytial virus. Now, this does have a vaccine that's out there. It's also called human respiratory syncytial virus or human orthopneumovirus. This is a very common contagious virus that causes infections in the respiratory tract. It is a negative sense single-stranded RNA virus. Negative sense in the sense that it has to basically have itself replicated, and it has to go into the positive sense if you want to be able to read the information to make the proteins that are construct the RNA virus. What are the signs and symptoms of the respiratory syncytial virus infection? Most of the time, the most common ones that will appear usually 4 to 6 days after exposure to the virus. You will see adults and older children. They have what they kind of consider like a mild cold-like symptoms or signs. That may be congested or runny nose, dry cough, low-grade fever, sore throat, sneezing, headache. But what about more severe cases? RSV can spread to the lower respiratory tract, causing pneumonia or bronchiolitis. You can have inflammation of the smaller air passageways entering the lungs, which of course makes it more difficult to breathe. In those cases, you have signs and symptoms that include fever, severe cough, wheezing. Now, the wheezing is a high-pitched noise that's usually heard, with a stethoscope, obviously, on breathing out. You may have rapid breathing or a difficulty breathing. The person may prefer to sit up rather than lie down. And because there's not as much gas exchange, they may start to begin to take on a bluish color in the skin. And this is due to the lack of oxygen, cyanosis. Now, infants are most severely affected by RSV. The signs and symptoms of severe RSV infection in infants include short, shallow, rapid breathing, struggling to breathe. Their chest muscles and skin pull inward with each breath. There's a cough. They are poor when it comes to feeding. They have unusual tiredness, a lethargy, and an irritability. Now, most children and adults recover in 1 to 2 weeks, although some might have to have repeated wheezing, severe and life-threatening infection. This may require a hospital stay, and definitely would when we have a premature infant or anyone who has chronic heart or lung problems. Usually the medication for treatment. We don't usually use antiviral meds here. It's not normally suggested to fight the infection because what happens is most RSV infections go away on their own in about a week or two. Okay. And here you see a couple of things. This is the diagram that you see of an RSV virus, okay? It's got a single strand of RNA, and these are nucleoproteins, so they protect that strand. You will have inside here a large polymerase protein that allow, once this is inside the cell, for replication, okay? We'll also have a phosphoprotein here. If you go to the next level, which is this area of protection here, you're going to start seeing the matrix proteins. And then you have attachment glycoproteins on this outermost layer. And these are glycoproteins. You have also fusion protein and the small hydrophobic protein right there. Okay? Now, this is giving you the basic rundown. If you have symptoms, whether it's for kids, etc., how to protect against it, and what is the distinguishment in the sense of what would be a mild case or a severe case. So now we're going to move into another area, sinus infections. We've been dealing mostly with upper respiratory infections or the lower respiratory infections in the lungs. So what is a sinus infection? It's a condition in which the cavities around the nasal passages become inflamed. Acute sinusitis can be triggered by a cold or allergies and may resolve on its own. Chronic sinusitis lasts up to 8 weeks and may be caused by an infection or growths. To help you understand this, keep in mind something. Some of the sinuses, if you've ever seen the facial x-ray, they have small apertures leading into the nasal cavity. But inside of that, they kind of broadly widen out in these sinuses. They can be great cultivation areas for various types of pathogens like bacteria, etc. Also, because of the inflammation, the sinuses may become blocked. They will not leak out what's in there. And that sometimes is very difficult for two reasons. One, you have the continuation of the infection, which would lead to further pain and discomfort. Sometimes decongestants help. But the other thing that happens is this, excuse me, in sinuses, and you have actively metabolizing bacteria, you're going to start seeing the amount of gases in that sealed sinus reduce. As the pressure is reduced, this is where you're going to start getting more pain. And really what happens is you have to have some type of nasal emptying that occurs. These sinuses have to be emptied. Now, you got to keep in mind also that with chronic sinusitis, it'll last up to 8 weeks. It may be caused by an infection or growths. And what I mean by growths are, yes, fungal growths would be one situation. Symptoms include headache, facial pain, runny nose, nasal congestion. Acute sinusitis usually doesn't require any treatment beyond symptomatic relief with pain medications, nasal decongestants, and saline nasal rinses. Now, chronic sinusitis may require antibiotics, but here's the trick. The sinusitis might be caused by viruses instead of bacteria, which means that antibiotics aren't going to do anything for a viral infection. If it's bacterial, or if a bacterial infection, a secondary type, develops, one treatment of choice is amoxicillin clavulanic, otherwise known as Augmentin, or levofloxacin or moxifloxacin. Now, in patients who have a severe allergy to penicillin-like drugs, usually the alternative is doxycycline, okay? But usually, 70% of all sinus infections go away within 2 weeks without antibiotics. Here are those tricky little cavities that we're talking about here. Here's a sinus here and here. And what you have here, these overhanging structures, are basically the nasal conchae. You have some openings up in here for the ethmoid sinus, of course, the frontal sinus. You have the maxillary sinus, which really is above the maxillary jawbone. You're also going to notice that in that nasal septum, you can have it, it's more on this side than on that side, Doc. You don't have bilateral infections a lot of times. It depends. You take a look down here, this is another more sagittal section, and you can clearly see where the ethmoidal sinuses are, and the sphenoidal sinus is right here, and the maxillary sinus is right here, and all of these areas, including the frontal sinus here, are areas where you would have types of infections, okay? Now, the proximity of the paranasal sinuses to the orbit, or the intracranial structures, and you can also see the cavernous sinuses. You probably have heard someone who had sinusitis, and they say, oh, it's right behind my eyes. It hurts like heck. Okay. Here is where we have the pituitary gland. Here's the optic chiasm. If you move forward, you've got what? The eyes are here, okay? And so you have the maxillary sinus being a possibility, and there is, it says natural ostium of the maxillary sinus. Basically, this is where it would drain. And you have these air cells, which are similar to the sinuses. They can get plugged up. You can have a buildup of material there, and it can also cause pain. Okay? What you have beyond the pituitary, of course, would be the eyes here. Notice where you can see the sinuses here, okay? And also you have, here's where the optic chiasm is, the sphenoidal sinus, etc. And I know that sounds kind of detailed, but it's almost like the sales routine that people say, location, location, location. When you talk about sinus infections, they could be lower, in the lower part underneath the eyes. They could be more behind the eyes or above the eyes. And that helps the doctor to try to make a determination of which sinuses are really having this infection. You also have to take a look at these computerized tomographic findings, okay? The CAT scans, as we call them. You see basically the cavernous sinus thrombosis, and it's secondary to the acute sphenoid sinuses, okay? So what you see here is right here. You have it right here by these arrows, here and here, and then back here and here, okay? One of the problems that will also occur is that, hey, these will not go away. They've got to be dealt with. In some cases, doctors will literally have to go in and put a small hole to allow that sinus to drain and basically rinse through that sinal cavity with saline. Okay. Now, this is a really nice concept map here to deal with acute bacterial sinusitis, and the recommendations by the Clinical Advisory Committee on Pediatric and Adult Sinusitis. And so you deal with, the signs, symptoms of viral rhinosinusitis, common cold or influenza. If the symptoms are no better or worse after 7 and 10 days, you can start thinking, maybe it's bacterial. Maybe we need to treat it with antibiotics. What if we get no resolution? Maybe you have a resistant pathogen there. Now you have to switch antibiotics for the hope that those new ones will take care of the pathogens not covered in the first course of therapy. Let's say you have symptoms that are less than 7 days. There's no recent antibiotic therapy. Therefore, you have probably more likely viral. And in this case, they say symptomatic treatment. So you would basically try to treat if there's any pain, discomfort, low fever, etc. What you're doing is just treating the symptoms. If you get no resolution or a worsening of the symptoms, then maybe you have now got a much more clear picture that it's going to be a bacterial infection. If you've gone through all of this, there's no resolution, you have to do a sinus CAT scan, and you may have to bring in an ENT consult where the sinus may have to be aspirated and sinus lavage, and as well as having some antibiotic there. That's where I was talking about going in and actually finding the particular infected sinuses and punching a hole to do a clean out of the fluid that's present. Okay. Next, otitis media. Now, acute otitis media, AOM, is defined as an infection in the middle ear and is the second most common pediatric diagnosis in the emergency department following upper respiratory infections. Okay? You got to keep in mind that these infections are usually caused by either bacteria or viruses, but we got a few little surprises here. First off, let's talk about the bacterial organisms that play a role. They could be Streptococcus pneumoniae. They could be also followed by a non-typable Haemophilus influenzae or Moraxilla catarrhatus. Now, what if it's more viral? Then you're dealing with, for example, respiratory syncytial virus, coronal virus, influenza virus, adenovirus, human metapneumovirus, or picornavirus. What are the symptoms? Usually, these symptoms are going to show up after a cold. They may include ear pain, loss of appetite, trouble sleeping, trouble hearing in the ear that's blocked, a feeling of fullness or pressure in the ears. You may actually get some drainage, and it may be yellow, brown, or white. If you have drainage, that's indicating that the eardrum has broken. Most of these ear infections go away on their own. There is a treatment for sometimes children need antibiotics, pain-relieving medications, or ear tubes. The antibiotic treatment may include amoxicillin, amoxicillin clavulanate. Now, ear tubes. What is the general principle? And sometimes you have kids that are always, every year, 18 months or 6 months, whatever, they have another otitis media attack. So the doctor will go in, and the principle is this. They put a very fine tube into the tympanic membrane, the eardrum. That's going to allow not only leakage out of the fluid, but air. Some of these organisms may be more anaerobic and wouldn't work well or live well with um, the air, the oxygen. Now, what about when they take the tubes out? Very rarely do they have to take the tubes out, because after a period of time, the doctor will come in, take a look in the ears, and they've fallen out. And the hole in the drum is slowly beginning to heal. There are some kids that, doctors are hesitant to just keep saying, let's bring them in. I worked at one hospital where literally all day long, every 30 minutes, this room had the eardrum, that one had the eardrum. So the surgeon would go, and of course change gowns, obviously, from one room to the next, put in the tube, let the rest of the surgery crew finish up. And while that surgeon is going, they would go into the next room after they've changed, obviously, and put in the tubes. And literally, this was the situation. They were doing this every 15 minutes for an 8-hour day. Yeah, that's a lot. But this was the only way to help these kids. And many of these kids, when they get older, they don't have any problem. A lot of times what happens is this is because of the way the middle ear is constructed. It's smaller, and so something that cultivates in there will cultivate and quickly create an infection in that area. As you can see here, one of the things that goes on also is this. The location and the arrangement of eustachian tube. So here we have an adult, here we have a child, here we have a pediatric ear. Now, in this middle ear area, you'll notice that the pharyngotympanic tube, otherwise known as the auditory tube, is relatively easy to access. And this is going to, of course, empty into the back nasal area or throat. Here's your drum, eardrum right here. As someone gets older as an adult, you see the tube elongating, and it will become more a cross between vertical and horizontal, angular. So organisms that are here are not going to be as easily moving up into the middle ear. Whereas with a kid, a child, you have the situation that you have it more shorter, this tube, and it's more horizontal, so it's easier for organisms to move up from the outside of the auditory tube to the middle ear. Now, the tympanic membrane. If you have an otoscope and you look in the ear, what are you going to see? Well, you may or may not see an air fluid level. In other words, the fluid's on the bottom, the air's on the top. You may not see as much, but you will possibly see the malleus, which is directly attached to the tympanic membrane. What you will see is purulent fluid that's trapped behind the membrane of the middle ear. You will probably also see the tympanic membrane bulging out because of the volume of material there. If you got little kids, one of the hints also of symptoms or whatever is they're constantly tugging on that ear where the infection, on that side where the infection occurs. So what they would do, the surgeons would be, they would basically put a hole, put the tube in, let it drain out, and give it so much period of time, check on the patient. And what I mean by period of time, it could be several months. And that tube also, nowadays, they found will a lot of times just fall out. Okay. So here is the acute otitis media treatment algorithm. This is sort of like a concept map. And what it really is to help doctors to come to an understanding of, okay, what are you going to do? How are you going to do it? Etc. Especially if you have a pediatric patient. And you can see, start off with antibiotics. You may or may not. If you don't, you'll watch. If nothing has resolved itself after 48, 72 hours, then you have to really go to the antibiotics. You have to also ask yourself, is there a penicillin allergy? Okay. If it's yes, then you have to consider other situations, other types of drugs, etc., depending on also whether it's a severe disease or it's been reoccurring. Okay. Finally, if there's no penicillin allergy and it is severe disease, you may have to go to the big guns of antibiotics. Okay. Amoxicillin, amoxiclav, so clovulamide. And you may start off even also with ceftriaxone. Okay. Notice the time periods here. 48, 72 hours. 48, 72 hours. This is not something like, okay, we'll see you in a month. This is, we want to find out what's going on, if there's been any change, reduction in symptoms, etc. And if not, you move to the next step relatively quickly. Because also what you want to do is reduce the suffering of your pediatric patient. Now, this is the pathogenesis of otitis media. Keep in mind that you have IgAs, which means immunoglobulin A. Okay. You also have IgGs, immunoglobulin G. Let's say we start off with a situation where you have bacterial infection. It could be any one of these bacterias, and you have to consider what you're going to do. Now, there are other factors that play a role in this. It could be eustachian tube dysfunction here. Okay, not only is it short and perhaps horizontal, but it may have other defects in it. Viral infections, and you can see the key viruses here. And then finally, you have to ask yourself, is there something that's deeper down for the patient? Allergy, a cleft palate. If they have deficiencies in selective types of immunoglobulins, or if they have what is called ciliary dyskinesia, where some of the ciliary cells that might move fluid along aren't functioning at all. Okay, now we're going to move from the ear to the pharynx. Now, pharyngitis, which is an inflammation of the mucous membranes of the orthopharynx. Heads up, I'm not talking about tonsillitis. I am talking strictly about the pharyngitis, okay? Most cases, you're going to see this caused by an infection, either bacterial, viral, or fungal. Usually the bacteria is the first, then you get sometimes the viral, unless there's been previous problems with viral infections. Very rarely, but still present, is the possibility of fungal-based infection for pharyngitis. So let's take a look at the bacteria first. Group A strep pharyngitis is an infection. This is of the orthopharynx caused by either S. pyogens. And you got to keep in mind, S. pyogens are gram-positive cocci that grow in chains. You can also have pharyngitis that can occur with mononucleosis. Now, mono, of course, causes the Epstein-Barr virus. We all call it mono, but it'll a lot of times lead to inflammation, etc., around the pharynx. Fungal pharyngitis, this is the Candida albicans, occurs in the setting of usually a patient who is under immunosuppression or chronic steroid and antibiotic use. Okay? A lot of times, knowing whether the person has a sore throat is viral or bacterial is usually determined by the symptoms. So, viral sore throat usually consists of cough, swelling in the throat, runny nose. Bacteria, sore throat, are typically accompanied by nausea and vomiting, stomach ache, and there's no cough. So, how do we treat all this? Well, viral pharyngitis goes away on its own. Sometimes, to alleviate some of the discomfort, you use a salt water gargle. You may add pain relievers and extra fluids. Basically, you're making the patient comfortable as the virus is fought off by the person's immune system. Bacteria pharyngitis is treated with antibiotics, usually penicillin or amoxicillin. Now, with fungal, this is a little bit more tricky. Fungal pharyngitis, you have to use antifungal medications. Chlorotrimazole, miconazole, or nystatin. If you have very severe infections, the most common treatment is fluconazole, and it may be taken either by mouth, oral, or through a vein. So, in other words, you may have to have an IV, basically delivery. And you can see this here. Here's the pharyngitis. You can see how it's kind of red back there, etc. But interestingly enough, you have the peritoneal sole abscess, which is up in there too. Okay? Now, this is a really nice little image I picked up. This is to help you if you had to make a decision. Is it bacterial? Is it viral? Is it fungal? Well, the key physical findings in orthopharynx in viral, bacterial, and fungal pharyngitis. Viral, you're going to have the tonsillary arrhythmia, meaning that the tonsils are going to be swollen, red, etc. The pharyngeal area will also have redness. If it's bacterial, you'll have the palatal petechiae. In other words, petechiae is little breaking of small capillaries. Okay? And then you're going to have an exudate tonsillar hypertrophy. So, in other words, you're going to have the tonsils getting bigger, but they're going to be leaking out material, usually pus, etc. If it's fungal, this is a little different. You have the angular cheilitis, and you have curd-like plaques on the tongue. Sometimes you'll end up with this tongue actually having open sores. Okay? Now, here is the streptococcal pharyngitis. You'll notice that there is an abundance of whitish stuff here, but you'll notice here the tonsils and the back of the pharynx, all red, all red. These are inflamed. If you had viral pharyngitis, you have a more discrete punctuate pattern versus the strep pharyngitis. Now, what I mean by that is if you notice the tonsils right here, they've got like little divots or holes in them. Also, the back of the pharyngitis is red. Okay? And you can see some of the growth on the tongues as well. Now, Netter set up guidelines for the diagnosis and management of Group A streptococcal pharyngitis. Okay, so here you have this. If you have the clinical and epidemiological features, nothing suggestive of Group A streptococcal pharyngitis, then you start going after symptomatic therapy, make the patient comfortable, etc. If you have a possibility of Group A streptococcal pharyngitis, that's serious. How do you determine it? Have that rapid antigen detection test. These are the tests that basically even doctors and offices can do. They take a sterile swab, they swab the back of the throat, they put it into a very small ELISA reaction. It looks almost like it's smaller than a playing card. It's about like 1 inch by about 2 inches. If there is a reaction there and it's positive, then you have to move right into antimicrobial therapy. But what if it's not just possibly Group A? Simple. You send the throat culture out. If it's positive, you still go through the antimicrobial therapy. And you can see here we have the Epstein-Barr virus pharyngitis. Notice that you have the swelling around the throat here. You have the enlargement of the tonsils here. This is all viral now. Okay? And if you go to acute rheumatic fever, which can come from some of this, from pharyngitis, this is if it's not treated and it continues down the road. It's going to affect skin, joints, heart, and the nervous system. Finally, if they cultured the sample and you had Group A strep there, this is what you're going to use. Now, this, of course, is a blood agar plate. In a blood agar plate, you can make the determination if it's alpha hemolysis, beta hemolysis, and gamma hemolysis. To explain that very quickly and basically, certain organisms, if they're growing, they are going to grow and basically they of course are going to use the blood that is in that agar for their nutrients. But what's going to happen with certain strains of bacteria is they're going to take on sort of like this weird metallic green sheen. Okay, that's alpha hemolysis. In beta hemolysis, it's very interesting because, again, the bacteria are taking up the blood cells that are mixed in with the agar. And usually the blood cells are something like sheep or something else like that. But what you see is the colony, and then around that colony immediately, it's all clear. No red. That's beta hemolysis. Now for gamma hemolysis, you have your strain, you're having it run through on the blood agar plate. You have the colonies formed, but there's no change on the outside of the colony. No color change, no loss of color, etc. Some of the streptococcus will produce hemolysin. Hemolysin breaks down the red blood cells and allows them to access the proteins and the iron that make up hemoglobin. Okay? So, let's talk about chronic obstructive pulmonary disease, but acute exacerbations. Now, look, when I talk about an exacerbation, this is things that suddenly are going to get worse. That's why they're treating AECOPD as very important. But I want it clear. When you say COPD, that's a grab bag. That includes emphysema, chronic bronchitis, asthma, bronchiolitis, and cystic fibrosis. Okay? When you have this acute exacerbation, this is a clinical diagnosis that's made when the patient with COP experiences a sustained increase in cough, sputum production, and/or dyspnea. All right? So now, some people may have a combination of COPD and emphysema, or COPD and chronic bronchitis. Okay? Most common cause of these exacerbations is you end up having another infection in the lungs or in the airways, the breathing tubes. So, if the infection is from a virus, but it may have also be caused by a bacteria or less common types of organism, let's talk about what are the most common organisms that cause this problem. Moraxilla cathratus, Haemophilus influenzae, and Streptococcus pneumonia. For viruses, rhinoviruses, the rhinovirus that causes colds, respiratory syncytial virus, these have been implicated as causes of AECOPD in several studies. Now, during the influenza season, the prevalent strain of influenza virus may also be an important viral cause. This is particularly noteworthy in the elderly. That's why public health has been pushing for the elderly to get vaccinated against the flu. Even if the flu and the vaccine don't completely protect the individual from the flu, it'll be a much milder case. And usually you dodge the bullet of the AECOPD. AECOPD has clinical consequences ranging from self-limited illness to a progressive respiratory failure. So how do we treat it? Well, this depends on the severity. Acute management of this involves the use of bronchodilators. These are usually going to be short-acting, such as albuterol, which is a short-acting beta-2 adrenergic agonist, or ipratropium, which is a short-acting muscarinic antagonist. It may include steroids, such as prednisone, antibiotics such as amoxicillin, doxycycline, trimoxazole, also oxygen, and non-invasive ventilation. Hospitalization may be required, especially if you're dealing with severe exacerbations. Now, by the way, when I say oxygen and non-invasive ventilation, sometimes oxygen will be put in and you've seen this nasal drip. Okay, so it's around the nose and it's just to boost extra amount of oxygen as the person's breathing in. You can never really give a patient 100% oxygen because all of that oxygen is going to create free radicals and cause damage to cells throughout the systemic circulation. You also have the non-invasive ventilation, so it might be something like a mask where they set a certain amount of pressure just to enhance the capability to get air into the respiratory system. So here we have a clinical evaluation of the exacerbation. Yes, I'm having sometimes difficulty. Bear with me, please. The woman is coming to see her physician. Okay? You have to also understand some of the other issues that may pop up. For example, if we talk about an exacerbation of asthma, it could be because in part you have serious air pollution occurring. Okay. If you take a look, they will, of course, do a variety of tests. They may do a chest x-ray. They may do a sputum study. Now, a sputum study has to go to the point of seeing what cultures, what organisms they're going to find in that sputum. Here we have the cardinal manifestations of exacerbation of COPD. You have the pathogens that interact with the bronchial mucosa. They're going to be eliciting inflammation that leads to mucus hypersecretion and a bronchospasm, and which is going to cause symptoms of the exacerbation. Okay, so basically it's 1, 2, 3, 4. Okay, pathogen acts on the bronchial mucosa, greater inflammation, mucus hypersecretion, and bronchospasm. Okay, now with dyspnea, the person is having a hard time breathing. With this other situation, you have a productive cough. So every time somebody's coughing up, they're coughing up, that might be the mucus. It may be mucus mixed with pus, etc. Okay. Now, how do we treat it? Well, it can be easy to treat in some situations, and others not so much. What they first do is they're going to determine the forced expiratory volume in 1 second. If you've never taken those tests, basically it is where you have sort of a spirometer, and the spirometers are not the big machines anymore. They can be something as simple as walking into the office, and there is a little meter device that has a USB connection from that device to the computer, and you go through some prep, and then you basically take a deep breath and have to try to force out all the air possible. And the amount that is forced out in the first second is usually the amount that is critical. That's the FEV1. Okay. So if you have an uncomplicated COPD, you have no risk factors. So age is less than 65, FEV1 is greater than 50% predicted, less than 2 exacerbations per year, no cardiac disease. These are the types of antibiotics that the patient would face. Now, you have a complicated COPD, where you have one or more of these risk factors. Age over 65, FEV1 less than 50% predicted. 2 or more exacerbations per year, or the presence of cardiac disease. Then they're going to bring out the big guns and bring out these particular types of antibiotics. Okay? Now, one other thing to keep in mind. How do we deliver some of these drugs? Not always the antibiotics, but also some of the drugs that will reduce inflammation, etc. You have the metered dose inhaler devices that you see nowadays. A lot more people see them for treatment of asthma. Okay. But let's say we have an individual that's having a lot of difficulty. They might have problems and they're in a panicky kind of state. And what you do is you put the liquid medication here, have them hold on to it, open their mouth, and so a compressor forces the material in. You will see it vented out as the person is breathing out. Okay? So we've finished week 9. The suggestions to get ready for things. Obviously, week 10 is coming around the bend, and you will have your exam then. What I do encourage you to do is review the lecture PowerPoints, read all the supplemental articles in module week 9, View all the videos in Module Week 9. Okay? Make sure you read the assigned sections of the text. You also want to participate and complete the discussion for Week 9. And then finally, complete the quiz for Week 9. Have a great day.